On behalf of I am in Nagpur branch. Dr. Rajesh Saurmande, Secretary. I am in Nagpur. I welcome you all. Because of chronic, acute high-grade fever, our patient Archana ma'am is not here. She is not well. So I request Gauri madam to welcome all the guests and speakers and chairpersons. Gauri ma'am, please.
A very good morning to all of you. On behalf of Indian Medical Association Nagpur, I welcome all the speakers and all the audience for today's webinar on arthritis. We all know arthritis is a condition which afflicts joints, causing inflammation and even stiffness and restricted mobility at times. And any condition which restricts the mobility in this fast-paced world, be it paralysis or arthritis, it definitely comes in the way of progress in life and career. So, and even arthritis is even worse because there is a lot of pain, unlike paralysis. But the good thing is there are a lot of advancements in this field about which our eminent faculties are going to enlighten us. So we have faculties from renowned faculties from Bangalore and even from our city. I welcome all of them, all the speakers, and welcome the audience once again. And I hand over the mic to Dr. Rathi for further proceedings. Thank you.
Thank you, ma'am.
Dr. Dilip Rathi is moderator for today's webinar. So, Dr. please continue.
Thank you, Rajesh. Thank you, ma'am. Good morning to all panelists and attendees. First, I would like to thank IIM Nagpur for holding this webinar on arthritis. Arthritis, as you know, it's a day-to-day disease and day-to-day problems. And people from all faculty are seeing patients from right from with physician to general practitioner, orthopedic surgeons, rheumatologists, be it anyone, the patient keeps on moving from one person to other. And been more than 100 reasons or multiple reasons for arthritis, right from inflammatory to degenerative to post-traumatic to autoimmune. So it's a wide survey requiring a wide holistic approach, right, in diagnosis and in fact in multimodal approach for its management also. So here we would be discussing arthritis, right, in from the rheumatology perspective, right, in from the surgical perspective to exercises to lifestyle changes to diet. So we have a galaxy of eminent speakers here who also would enlighten us on the first. In this series, we'd like to welcome Dr. Shaili Chandak from Nagpur. Shaili has completed her MBBS and MD from JNMC Varda. And after completing that, she has done her fellowship in rheumatology at Sakra World Hospital, Bangalore. She has been professionally associated now with Kingsway Hospital, Nagpur, and with her vast clinical experiences, various fields in hospitals in Nagpur and Bangalore. And she has made many papers to her credit for presentation. So I'd like to welcome Shaili for her talk on scope of rheumatology.
Good morning to one and all. Thank you so for such a wonderful introduction. I would like, at the onset, like to thank IIM Nagpur for giving me this opportunity where we could just have a glance at the spectrum or scope of rheumatology per se. That is my topic for the day. And it's an honor to share the virtual stage with my teacher and mentor, Dr. D.G. Dharmanan. So thank you for this opportunity. Not taking time ahead, let's start with the presentation for the day, which is scope of rheumatology. So rheumatology has evolved over the years. It is something which has been evolving rather. So it is a science that deals with the muscles, bones, joints, skin, and musculoskeletal system. Rheumatic diseases are chronic, multisystemic, and predominantly autoimmune in nature. And thus, we always need a multidisciplinary approach in treating rheumatic conditions. Origin of rheumatology can be traced back to the medieval times where gout and osteoarthritis have been documented even in Charak Samhita. And even the Romans have a lot of literature regarding the osteoarthritis and the gout. Then came the drug revolution. Initially thought as a chronic condition having no remedies, gradually this improved as the new drugs came in the picture. Started 1899 with Bayer's aspirin, and Bayer tried this aspirin on his father itself, who was suffering from rheumatism. 1935 is considered to be a golden era where orafenone, which is a gold therapy, was really at its peak and helped improving or arthritis patient. Then came a combination of antibiotic and anti-inflammatory, that is sulfasalazine. Then came the picture where a lot of things changed, wonder drug in 1950s, which is cortisone. Cortisone has even received Nobel Prize by Edward Kendall and Philip Hench for the wonderful discovery and use of cortisone in the autoimmune conditions. Today's scenario also we have seen a dramatic improvement with cortisone use. 1988, rheumatoid arthritis, methotrexate was approved by US FDA for the rheumatoid arthritis treatment after a trial on 38 patients. 1998, there were two drugs. One was leflunomide, named as Arava, and the first anti-TNF agent, etanercept, was approved. 1999 was infliximab. 2006-7 we had a better drug which was rituximab or biological, which predominantly works on B cell depletion. And 2017 is the era of small molecules. So if we see the spectrum, rheumatology drug has evolved from steroids to NSAIDs to DMARDs and then biologicals and small molecules. The spectrum of rheumatology is basically a huge spectrum starting from arthritis to musculoskeletal disorder. This includes arthritis of all kinds, inflammatory, degenerative, connective tissue disorder, soft tissue rheumatism, chronic widespread pains, metabolic bone disorder, immunomodulation support to other specialties, and musculoskeletal disorder or orthopedic office disorders. Let's focus on certain diseases and try to see what happens. Coming to rheumatoid arthritis, which is very common and the majority of us have seen some cases of rheumatoid arthritis. The presentation is again varied. In the early phases can be seen as stiffness, fullness or swelling of the PIPs and the MCPs seen in the very first picture, followed by some deformities, bony swelling, that is between the nodes, then overriding of the claws and the deformities at the toes, which we can see. Rheumatoid not only involves the joints, but also affects the lungs and eyes. That is what has been seen, and that is what is very commonly seen also. Spondyloarthritis, the spectrum is really huge, predominantly involving the axial skeleton, but also has a predilection for peripheral skeleton also. Spondyloarthritis encompasses of reactive arthritis, ankylosing spondylitis, psoriatic arthritis, arthritis associated with inflammatory bowel disease, and undifferentiated spondyloarthropathy. Ankylosing spondylitis is usually seen at the young adult male. The onset is early, somewhere between 18 to 40 years. Above 40, it's really doubtful whether it is ankylosing or some degenerative condition. The first picture shows that syndesmophytes are getting fused, which is suggestive of a bamboo spine. Second picture is of sacroiliac joint, where we can see sclerosis on both the sides. And third picture is of acute and anterior uveitis, which can itself be a sole presentation or the first presentation of underlying ankylosing spondylitis or spondyloarthropathy. The next one is the psoriatic arthritis, that we can see. The first picture shows a DIP swelling, that is distal interphalangeal joint swelling, which is not seen in rheumatoid arthritis. Psoriatic nails is the second picture, plus you can see dactylitis, that is the sausage toes in this picture. Third picture is again suggestive of enthesitis, where Achilles tendon is seen inflamed on the right side, and arthritis mutulens, where there is complete damage or destruction of the joints in psoriatic arthritis. Moving towards connective tissue disorders, the commonest or the one which has a multi-system involvement is lupus, predominantly seen in females with a pregnancy age group or childbearing age group. The first one we can see the hard palate ulcer, which is one of the pathognomic for lupus. Second one is a malar rash, sparing the nasolabial folds. And third one is the discoid lupus erythematosus, where we can see chronic scarring is seen in DL. Lupus is a disease which involves multi-organ from head to toe, everything in various forms. Lupus can have various manifestations, maybe the first presentation, or maybe when the disease is not controlled, we can see new manifestations. Moving ahead is scleroderma. The name itself says thickening of the skin. Scleroderma can be divided into two variants, diffuse and limited. The first picture shows sclerodactyly. The second picture shows the gangrene of the tips of the fingers. The third picture is the Raynaud's phenomena, which is quite classically seen in this picture. And the fourth one is the lung fibrosis, which actually restricts the breathing capacity, the mobility of the patient, and the lung involvement may lead to even pulmonary arterial hypertension, PH. Muscle diseases, yes, myositis and dermatomyositis, basically proximal painless weakness can be seen. And in dermatomyositis, there are a lot of cutaneous manifestations also noted. Coming to vasculitis, vasculitis is nothing but the name suggests inflammation of the small blood vessels or the large blood vessels. EULAR has classified vasculitis into three major categories depending on the size of the vessel, that is large vessel, medium vessel, and the small vessel, which are further subcategorized according to the pattern of involvement. Again, vasculitis has a spectrum of presentation starting from cutaneous to eye involvement to renal, lung, and the upper GI system, so on and so forth. Crystal arthropathies, one of the very common crystal arthropathies that all of us have seen is gout, which is because of urate crystal deposition, predominantly involving the MTP, first MTP, or the ankle joint, but gout can be polyarticular also at the same time. Another crystal arthropathy that we can see is calcium pyrophosphate and calcium oxalate, which affects the mobility, restricts the range of motion of the joints. Calcium pyrophosphate and calcium oxalate is basically a disease of elderly. Moving ahead is fibromyalgia, which is a part of soft tissue rheumatism. It is common in 3% of the female worldwide. Fibromyalgia can have more than 25 different presentations and variations. It's just how you interpret those signs and symptoms. History taking and clinical examination is very important to come to a conclusion or a diagnosis of fibromyalgia. Another thing is benign hypermobility syndrome. This is not a disease, but this is just a condition where your ligaments and tendons are comparatively more lax compared to the other population. There's a score which is called as a Batten score, which helps diagnosing benign hypermobility syndrome. A score of 9 is considered to be a positivity for benign hypermobility syndrome. So this is all about the diseases. Coming to the blood test, which are being ordered by us here and there, but do we really need to do them? Think before ordering this test, because ordering tests is easy. Interpreting those tests is really a difficult when there is no clinical correlation. So hence, clinical and lab correlation is very, very important in rheumatology. Every ANA positive is not SLE, because there are other autoimmune conditions which may have ANA positivity, and pattern of ANA positivity makes a lot of difference in diagnosis. Every rheumatoid factor positive is not rheumatoid arthritis. The confirmatory test is anti-CCP for rheumatoid arthritis. Anti-dsDNA and ANA immunoblot is difficult to interpret without ANA positivity. So the protocol is first ANA immunofluorescence, followed by ANA immunoblot, which covers complete 17 antigen to assess the organ involvement. Above tests are diagnostic or used for screening tests, but they are not the prognostic tests. So while treatment, we do not chase rheumatoid factor to become negative if it turns out to be positive in any patient. All these tests are as good as a pre-test probability only. So we need to think and rethink before ordering any of these immunological tests. Apart from rheumatology, as I said, as I said in the beginning, this is a multidisciplinary approach branch where you need opinion or you need to be friends with other departments, starting from ophthalmology to orthopedics, because the diseases itself are multifaceted in their presentation. So we have to be friends with ophthalmology, dermatology, neurology, nephrology, gastroenterology, cardiology, pulmonary medicine, ENT, and orthopedics. The department, which was initially thought to be as just a rehabilitation department or just a branch of rehabilitation, over the years has become a multi-speciality. That is what is the growth of rheumatology in the present situation. And it is a evolving branch still. Every day there are new molecular discoveries, new drugs coming up as the immunological understanding is improving. So awareness is light, ignorance is darkness. So when we say rheumatology, we need to rethink and think again before putting a diagnosis and before ordering the tests. Thank you.
Thank you, Shelly. Thanks for enlightening us on grossly covering all aspects of rheumatology. If any question and answers for Shelly, you can post at a question and answer, and I'll shoot at her.
Yeah.
Then what's the test? Means how much weightage should be given to anti-CCP and other tests when patients comes with a polyarthralgia to an orthopedic surgeon? They do. So what's the protocol we should follow for polyarthralgia, and what test you feel would be an ideal one for them? Because most of us we write RA factor or other things, and anti-CCP, which is specific and how to interpret.
Sir, polyarthralgia or polyarthritis is not only rheumatoid arthritis. A lot of connective tissue disorders can also be present as polyarthritis in the very first presentation. So it's very important to understand the pattern of involvement associated with stiffness, no stiffness, what is history and the clinical relation. And we always ask for inflammatory markers along with rheumatoid factor and anti-CCP. Because if rheumatoid factor and anti-CCP both are negative, there is an entity called as seronegative arthritis. We need to consider that also. If there's active inflammation, then obviously there is some activity going on. So we need to consider what is the picture while we examine the patient and then take a call on the tests. So rheumatoid factor and anti-CCP should be ordered at the same time, sir.
Okay.
Okay, Shelly, thanks.
Thank you, sir.
Thank you. Thank you so much. I'm sorry, I forgot to introduce our chairpersons for the meeting today. So we have two chairpersons today, both eminent orthopedic surgeons from Nagpur, Dr. Ashish Chauve and Dr. Nitin Kimatkar. Nitin and Ashish, welcome. I would like the attendees to pose their question on the question answer session. They can do it after each lectures individually, or they can at the end of the session, we can have a free question and answer round also. So with this talk now, I'd like to invite Dr. B.G. Dharmanand, a doyen in the field of rheumatology. Sir, after passing his MBBS, MD, did DM from Madras Medical College. Then he worked as a specialized registrar in rheumatology at South End Hospital. He was one of the pioneers in starting the Department of Rheumatology as back as 1997 at Manipal Hospital, Bangalore. Currently, sir is a consultant rheumatologist at Vikram Institute of Rheumatology and Clinical Immunology. He is director of fellowships in rheumatology at all the hospitals, and currently he is the president elect for Indian Rheumatology Association. Sir has got a huge list of publications to his credit and has been a faculty in almost all the rheumatology conferences. So sir, we welcome you from Nagpur. So for your talk on the rheumatology.
Thank you very much, Dr. Rathi, for the introduction. And my sincere thanks to Dr. Shaili and IMA Nagpur for this invitation to be amongst you. And I had been to Nagpur about 4 or 5 years ago, and I had a very fantastic meeting with you all, and I have good memories of that visit. Yeah, so today my topic is current management of rheumatoid arthritis. And rheumatoid arthritis is the most common autoimmune inflammatory disease to affect the joints, and it affects women much more than men. And the management involves multimodal aspects, including medical management, physical therapy, and also surgical correction at the end stage of the disease. The entire aim of rheumatology now is to make an early diagnosis and also try to prevent surgery as much as possible. So going to the talk, I feel that the current management or the correct management depends entirely upon the correct diagnosis. If your diagnosis is wrong, the perfect treatment for rheumatoid arthritis will not work. So that is the most important aspect of managing any disease. The diagnosis has to be right. And the other tenet is early diagnosis leads to early treatment, and early treatment leads to much better prognosis. So it is important to differentiate arthritis and arthralgias. Arthralgias are extremely common in clinical practice. Every viral disease can produce arthralgias. And many medical disorders like hypothyroidism, malignancies, diabetes, undetected diabetes is due to glucose toxicity can cause polyarthralgia. Peripheral neuropathy, diabetic neuropathy can mimic polyarthralgias, polyarthritis. And fibromyalgia, as Shaili had alluded to, can mimic rheumatoid arthritis. So it is important to differentiate arthritis from arthralgias. Arthralgias are pain in the joints. Arthritis is inflammation in the joints. So we should be able to document swelling of the joints, not periarticular structure, but in and around the joints. So fibromyalgia is a very common mimic. It affects the women more often, and patients do complain of swelling in this disease, but the swelling is more subjective than objective. The patients say that my joints are swollen, but as a doctor, we may not be able to perceive that swelling, or we may perceive it as a little bit of puffiness, which we see in and around the periods in most of the women. And these patients also have morning stiffness, which can last for 1 hour. But the clue is they'll have generally normal inflammatory markers. Most of your autoantibodies, including ANA, will be negative. And these patients also have multiple somatic complaints. If you ask any question, they may say yes. If you have asked, they have headache, they'll say yes. If you have any stomach problem, they will have irritable bowel syndrome. They have tiredness. They have symptoms attributable to many systems. So in a way, it's a multi-system disease, non-inflammatory multi-system disease. So this is the most common disease, which is mislabeled as seronegative RA and treated with immunomodulatory drugs in practice. So another major group which needs to be differentiated is inflammatory versus non-inflammatory group of diseases. Differentiation is important because the prognosis and treatment strategies vary. So osteoarthritis, particularly hand osteoarthritis. Hope you can see this picture on the top, which the patient has got swelling in the distal interphalangeal joints, proximal interphalangeal joints. But the swelling here is more bony. The Heberden's nodes, Borchards nodes, and the MCP and wrist look good. So this combination, DIP and PIP, and sometimes first carpometacarpal joint, this combination is more osteoarthritis. In contrast, this first one to the second patient. This patient has got hyperpigmentation on the metacarpophalangeal joint, which is post-inflammatory changes, And also you can notice subtle swelling in some of the interphalangeal joints, and DAP is spared. So the combination of proximal interphalangeal joints, metacarpophalangeal joints, and wrist, this combination, if they are swollen and there is pain on all the movements, and when you feel the joint, it feels boggy, then you make a diagnosis of polyarthritis, and then your test will have a stronger meaning. If a rheumatoid factor comes positive, then you can assume that the patient has got rheumatoid arthritis. So also for anti-CCP. Another concept which is very useful in differentiating rheumatoid arthritis from other types of arthritis is arthritis plus concept, by which what I mean is we have to look for the other symptoms the arthritis is associated with, or the company which the arthritis is associated with. So for example, arthritis plus lot of nail changes. If the patient has got rheumatoid arthritis, like arthritis, but the nails look very bad, looks like a fungal nail, this patient may have psoriatic arthritis. And again, arthritis plus anemia, arthritis plus ill-looking patient, if it is a young woman, think of an autoimmune connective tissue disease. And arthritis with a lot of bowel symptoms can be inflammatory bowel disease, Crohn's disease. And eye disease can be associated with, depending upon which eye disease. Uveitis is common in ankylosing spondylitis. Dry eyes and scleritis can occur with rheumatoid arthritis. And scleritis is very typical of Wegener's granulomatosis or granulomatous polyangiitis. So when you have a patient who presents to you with rheumatoid like polyarthritis, look, quickly screen these things. Is the patient looking ill? Does the patient have a lot of fever? And the patient is very in the extremes of age, like 70 plus. Then the differential diagnosis may be vary. Does the patient have muscle weakness? Whether the difficulty in walking is due to muscle weakness or a joint pain or a joint swelling. Rashes, neurological symptoms, unexplained anemia. Rheumatoid can have a hemoglobin of 9, but if it is 6, very unlikely to be due to rheumatoid alone. And bowel, ocular, and multi-system involvement. These are the red flags. And when you have red flags, the diagnosis will be generally different. It can be lupus, it can be scleroderma, dermatomyositis, and the spectrum. Even infective endocarditis can present with acute onset symmetrical polyarthritis with rheumatoid factor positivity. It can look like rheumatoid arthritis, but this patient will be sick and they will have a cardiac murmur. And hepatitis B prodrome can have RA-like arthritis. So this is where we have to differentiate. Once we have reasonably sure that we have not missed any of the systemic disease, then we know that we are dealing with rheumatoid arthritis. Shaili has already alluded to, if the pretest probability of rheumatoid arthritis is high, then a positive rheumatoid factor or anti-CCP adds very strongly to the diagnosis. Both the criteria which are available, the older criteria and the newer criteria, gives fairly good weightage to the autoantibodies. And also, most of the rheumatoid arthritis patients, when they have significant symptoms, will have either CRP or ESR elevation. So if the ESR and CRP are dot normal, if it is 2 millimeter ESR, pretty normal CRP, then think twice before attributing this illness to rheumatoid arthritis. We may be dealing with an illness which causes polyarthralgia rather than polyarthritis. Then coming to management proper. The principles of management is inflammation multiplied by time is equal to damage. Longer the inflammation stays in any organ, the end result is damage. Once there is damage, it is irreversible. So this is a very important concept in any autoimmune disease, for that matter, most of the diseases. Before the damage happens, we want to treat the disease, diabetes, hypertension, etc. Imagine any disease, chronic disease, this concept holds. Even a pimple which comes and stays for a longer time. If a pimple doesn't go away for months together, it will lead to small pock marks, scars in our face. The pimples came and went quickly, would not leave a scar. So we all have a window of opportunity to intervene quickly, and we have to treat to a target. A target is remission or no disease activity. So if you don't treat a rheumatoid arthritis, there is a gradual worsening over years, and the patient ends up in a wheelchair or ends up under the surgeon's knives for a knee replacement surgery. If you intervene with the correct drugs little later in the course of the disease, after 4 years, 3 years, 4 years, 5 years down the line, we may be able to slow down the disease a little bit and bring down the curve towards the lower side. But if you start fairly early, then you can flatten the curve little better. And very early, within few weeks of the disease onset, if you treat the patient aggressively to the target, we can make them near normal. So this is the principle behind which the entire rheumatology operates now. So a patient with rheumatoid arthritis will have a lot of disability even in the early stages. In the early stages, the difficulty is due to inflammation. The patient may have tiredness, they have swollen joints, but at this stage, it is potentially reversible. The same symptoms can occur with the patients whose hand looks like what is there in the picture, like this. And this patient also has got fatigue and a lot of pain, but in this situation, the damage has already happened and it is not reversible. So this is the window of opportunity which we are talking about. Earlier, we intervene with the most effective drugs and achieve a remission. The chance that it will progress along this line to deformity, which starts to look like a swollen joint to a deformed joint, can be prevented or at the most delayed to the maximum years. This is the timeline which Shaili had already taken you through from rehabilitation. Rheumatology was always in the corner, the outermost corner of any hospital in most of the countries. Even in UK, when I went to UK, in some of the hospitals, rheumatology was attached to rehabilitation department. So the departments of rheumatology and rehabilitation. So rheumatologists are rehabilitation specialists originally. Then some of the orthopedic surgeons took interest and they created medical orthopedics divisions. And once with the advance of new medications and immunology, and physicians took over and it became a medical specialty somewhere in mid 50s and early 60s. Coming to medications proper, non-steroidals, which is the most commonly used drug, but it should have a limited but a small role. So it should be used sparingly in the early stages when the patient has got a lot of pain. If there is no contraindication, we can always give an anti-inflammatory at an adequate dose for the shortest period of time. That once the disease is controlled, then we use it only on PRN basis or SOS basis to manage an occasional flare here and there. All NSAIDs are almost similar. There is not much of a difference in the efficacy in the adequate dose, full dosage. That means 100 milligram of diclofenac or 150 milligram of diclofenac will be equal to 90 milligram of etoricoxib. But individual difference in efficacy is very common. There may be a patient who responds very well to etoricoxib, but not at all to indomethacin. We see patients like that. And advent of new COX-2 inhibitors like etoricoxib and celecoxib, they have better gastrointestinal safety, but they are not better compared to conventional NSAIDs with regards to renal and cardiovascular safety. If you have to use an NSAID, use it with a PPI if it is not COX-2 inhibitors, and avoid NSAID in high-risk group, particularly elderly, ischemic heart disease, diabetics, and multiple comorbidities. It is not a good practice to prescribe 2 non-steroidal anti-inflammatories in the same prescription. Avoid this. people feel that paracetamol may be safer to combine with NSAIDs, but there is some data to say that combining ibuprofen and paracetamol and ibuprofen alone, when they had a study, ibuprofen plus paracetamol patients had higher risk of GI bleed. So it is not like fantastically superior. Tramadol can be an useful adjunct when you want to manage the pain rather than the inflammation. Steroid, without steroid, probably there's no rheumatology. And steroid was discovered by a rheumatologist. The Hench was a rheumatologist, and they won the Nobel Prize for that, as you have seen. And but we are using steroids. We have learned from the past adventures and misadventures, and we now know which is the right dose, safe dosage. So we are using it much more judiciously. So we can use, their strategies are, we can start with high dose in an aggressive rheumatoid arthritis, start with 40 milligram and quickly taper it over 3 months to 0, and continue disease modifying drugs. There is another strategy. We can use low dose steroids on a long term. Particularly we use it in patients who have contraindication for other drugs, or if they are already taken it for many years, we may not be able to stop these drugs. We use depomedrol or depot preparations for flare management. Intra-articular injections are very, very useful, and it can be joint saving. If you have a patient with flexion deformities, elbow flexion deformity, if it is not getting better with your methotrexate or whatever drug you are using, if you inject this joint early, you can save the joint. If you miss that, the joint will get damaged over time and get into flexion deformities. And IV methylprednisolone is not used in rheumatoid arthritis on a regular basis, except when there is rheumatoid vasculitis, which occurs in the very late stages of the disease. And steroids also have little bit of disease modifying effect, but for its side effects, we would love to use steroids on a long term, but long term steroids are actively discouraged now in practice. Then coming to the major drug, group of drug, or we call as anchor drug for rheumatoid arthritis, or they're called conventional synthetic disease modifying drug. Methotrexate is the most popular anchor drug. If methotrexate cannot be used for some reason, either intolerance or contraindication, somebody with a hepatic disease, non-alcoholic liver disease, or alcoholic, we may not be able to use methotrexate. In that case, we can use sulfasalazine or leflunomide as an alternate disease modifying drug. And we also use hydroxychloroquine, which is a mild DMRD. And cyclosporine, azathioprine, tacrolimus, iguratimod is a new addition. So we use the drugs when these drugs, the earlier drugs, are either contraindicated or not effective. We can use it in various combinations. We can add one by one or start with 3. Once patients are better, we can drop down 1. There are few strategies which we can combine these drugs. This slide simply tells us that early disease modifying initiation of drugs can lead to radiographic arrest of the progression. So the patients who started disease modifying drugs early, they have less erosion in the X-rays. So what are the lessons we have learned over the last 10 to 15 years? Early initiation of conventional disease modifying drug therapy. And we have also learned that we have to monitor these patients at a closer interval rather than giving methotrexate, ask them to come back after 3 months. We want to start on, say, certain dosage and see them every month, escalate the dose so that a full dose is reached within 3 months' time. And in a patient who is not tolerating oral methotrexate or inadequate responder to oral methotrexate, we are using subcutaneous methotrexate, with which we can get control in some more patients, because in a small group of patients, methotrexate is not very well absorbed by stomach. And we have learned about the additional benefits of steroids and safe usage of steroids. And we have learned a lot about using various combinations of disease modifying drugs. These are the common disease modifying drug and their dosage. Methotrexate is generally started at 10 to 15 milligram per week and increased every month by 5 milligram to reach 25 milligram per week by latest by 3 months time. Sulfasalazine dose is 2 to 3 grams per day. I see a lot of time doctor starting 500 milligram OD. That's never going to be enough. This is a big molecule. You need at least 2000 milligram of sulfasalazine per day. We can escalate to 3000 milligram per day. Leflunomide dosage is 220 milligram per day. Hydroxychloroquine 200 to 400 milligram per day. And igratimode is 25 to 50 milligram. Tacrolimus is 2 to 4 milligram. And we use in various combinations, as I've told you already. All patients who require these medications should have a baseline blood test. So that is the reason you need to be either a physician. If you are an orthopedic surgeon, you should have a physician mindset. I would like an orthopedic surgeon who is treating rheumatoid arthritis to carry a stethoscope and use BP apparatus. So this is very, very important. And the baseline tests are blood counts, liver function tests, creatinine, viral markers, chest X-ray, and urine routine. Viral markers are hepatitis B and C commonly, and sometimes HIV. And we monitor initially closely for every 4 to 6 weeks, then subsequently 12 to 16 weeks blood counts and a liver function test, and once in 6 months we do see the creatinine levels. Then comes to the major group of molecules which have revolutionized rheumatology, and these molecules have made rheumatology an attractive specialty. Nowadays, you will not believe that the top rankers in a NEET examination or a DNB examination for PG examinations are opting to go for rheumatology rather than the more fancied cardiology or nephrology. These molecules have little bit of glamour attached to it, and because it is directed against specific pathway in the immune pathogenetic pathway of rheumatoid arthritis. We know that TNF, tumor necrosis factor, plays an important role in propagating autoimmune process in rheumatoid arthritis. So they have developed almost 5 anti-TNFs, and these are the etanercept, infliximab, adalimumab, golimumab are available in our country. The B-cell depletion, Shaili mentioned, rituximab, which was originally discovered for B-cell lymphomas. They are also useful for rheumatoid arthritis and also in lupus and other vasculitis. Tocilizumab has got a notoriety after this COVID epidemic. It was thought to be the drug of choice for cytokine storm which occurred with COVID, but unfortunately the studies have got a failure study, and it is no more recommended to be used in COVID. And the current trend, probably the best thing happening to rheumatology in the recent past, is we have oral drugs which can be as powerful as biologicals in the form of small targeted synthetic small molecule DMRDs. The tofacitinib and baricitinib are the examples. Both are available in our country. Problem with these molecules are they are very effective, but still not everybody responds to all the drugs. Only 30 to 50% of the patients will have good response, and only 70% will have some response. So sometimes it's a trial and error. Use this drug first, it doesn't respond, you use other drug. Still, we don't have very strong biomarkers except for rituximab usage. Rituximab works better in somebody who has rheumatoid factor or anti-CCP positivity vis-a-vis somebody without this antibody positivity. There is an increased risk of infections. So that is why these molecules have to be given after screening for tuberculosis by doing Manto test, quantiferon TB gold, and a thorough tuberculosis history and a chest X-ray. Sometimes a CT scan if you have a doubt. And a viral screen for hepatitis B, C, and HIV, because they can get reactivated. And even after screening this, we need to have a continuous vigil and a low threshold to look for and treat for infections when you are using biological response modifier drugs. People thought that because we are going to mess up with the immune system, there might be an increase in the cancer risk, because immune system is absolutely required for cancer surveillance. So by reducing the immune system or modifying the immune system, there was a concern that whether we are going to increase the cancer risk. But most of the studies which have got now 10 years, 15 years follow-up has been very reassuring. There is no increased risk of malignancy except in some cases non-melanoma cancer, which is a kind of a treatable cancer. In our country, at least, we are using this drug as an induction therapy when the disease is not under control, and try to maintain the patients with conventional disease modifying drug. This strategy is being explored in many countries. I heard that there is going to be a talk on diet. I will not linger on. The basic principle is you need to take an anti-inflammatory diet. So pro-inflammatory food are processed food. Natural foods are anti-inflammatory. So vegetable-rich food and better omega-3, more omega-3, less carbohydrates, more spices, more tea, less salt. And there is increasing attention and interest in fasting and fasting mimicking the fasting and other similar technologies to alter the immune system. And when it comes to rheumatoid arthritis, we should never forget about the comorbidities. And comorbidities also help us to decide the appropriate drugs. So rheumatoid arthritis is an independent risk factor for coronary vascular disease. So we need to look for and treat all the coronary vascular disease like hypercholesterolemia, diabetes, metabolic syndrome. Advice to stop smoking and ethanol is very important. We have to encourage physical activity. There's going to be a talk on this. And statins and aspirin can be prescribed to the patient who have a higher risk. And rheumatoid arthritis is also an independent risk factor for osteoporosis. Apart from all the other risk factors, rheumatoid factor adds another risk independently. So we need to consider, particularly if they are postmenopausal and if they, more particularly if they are above 60 years, consider screening for osteoporosis and introduce bisphosphonates, and also encourage physical activity, because physical activity is the #1 stimulant for osteoblast activity. And of course, we always look for ways to prevent infection. And this is getting reinforced with COVID and COVID vaccines. So we try to use flu vaccines and pneumococcal vaccines in all rheumatoid arthritis patients who are above 50, 60 years. At 60 years, definitely yes. Below 50 years, depending upon how well they are and what are the other comorbidities, we can decide on using vaccines. And another big problem in our country is presence of non-alcoholic fatty liver. This is very common in obese people, metabolic syndrome people, and also diabetics. So we have to actively look for it, because methotrexate and steroid can worsen non-alcoholic fatty liver disease, which has become the #1 cause for cirrhosis in our country now, in the world now. It has overtaken alcohol as the #1 cause. And if alcohol is also there, it is going to worsen the situation. So where are we with regards to rheumatoid arthritis management? We are definitely able to give them symptomatic relief with medications. And if medications are not working, or at a later stage, our orthopedic colleagues can replace the joints and make them pain-free, and mobility can be restored. So we are able to prevent the damage with early onset of disease-modifying drug. Functional improvement we are able to do with medications, physiotherapy, and also the surgical methods. So we can't dismiss the role of surgeons, because until biologicals have come, the #1 major advancement which has advanced the life or quality of life of our patients with rheumatoid arthritis was knee replacement and hip replacement surgery. So their role is definitely there, but as a physician, we want most of our patients not to go for surgery. And when the patients are going in, we recommend surgery with wholeheartedness. So we are able to achieve remission with drugs. There we were able to achieve that. cure is still elusive. And there is a small hint that people who are very aggressively treated, some of them can go into a drug-free remission, but still that percentage is not more than 10%, 15%. That is still we are lacking. And predicting and prevention of autoimmune disease is still a dream, and still I'm not sure whether we are in it. So I think with this, I will stop my talk and I'm open to discussion. And my sincere thanks to the audience for the patient listening.
Thank you, sir. Thank you for this crisp and elusive talk on the current concepts and management of rheumatoid arthritis. So we have few questions for you. This is Dr. Sachin Dhote. He would like to ask which treatment approach you prefer, step down or step up in newly diagnosed RA with severe DAS?
If the new onset arthritis with severe disease activity, that's what you had meant. In that case, probably I would give them steroids, at least 2 disease modifying drugs. So 3 drugs which can work on the immune system. So steroid, methotrexate, and hydroxychloroquine. Or you can choose the combination differently depending upon the patient's profile. We would give them aggressively these 3 drugs. Sometimes even sulfasalazine is added or leflunomide is added, and try to achieve a control and taper it off. In a moderately active early disease, it is not wrong to try single drug. If at all we want to try single drug, it has to be methotrexate. If methotrexate is contraindicated, either leflunomide or sulfasalazine.
Okay, sir. Thank you. Hope it answers your question, Dr. Sachin. So there's one more question from Dr. Nitin Kimmatkar, one of our chairpersons, to either Dr. Shaili or you. He's asking what's the role of type 2 undenatured collagen in osteoarthritis? That was first question. And role of biologicals in RA and ankylosing. I think you have answered that biological part.
What's the first question? I didn't get the first question.
Role of type 2 undenatured collagen in osteoarthritis, ONEs.
I think there's going to be a talk on ONEs. And my simple answer is, at this moment, there is no definitely proven therapy in osteoarthritis, which can be backed by double-blind controlled trials. So all the recommendations, including rheumatology associations, orthopedic associations, general practice association, America, European, they don't recommend any specific drug for osteoarthritis. They only lifestyle modification, weight reduction, physio, exercises, and little bit of complementary therapy. Sometimes some of the recommendations say a little bit about acupuncture, somebody about a few other modalities. Glucosamine is included in some of the studies. But we don't know really. We really don't know.
Thank you, sir. Thank you so much. That was quite informative. So if any other question, we'll have it at the end of the talk.
Sure.
Now I would request Dr. Mukesh Ladha. Mukesh is an hip, knee, shoulder surgeon. His main interest is arthroscopy and arthroplasty. After completing his MBBS from PDMC Amravati, he has completed his DOR from Gulbarga and then DNB from Mumbai. Mukesh has been doing a pioneering work in robotics. He is the only first surgeon from Central India to be doing robotic knee replacements here in Nagpur, and has quite a few publications in journals also. Recent been the role of the accuracy and the preciseness of robotics versus conventional or computer assisted knee replacement. So I hand it over to Mukesh.
Thanks a lot for the introduction, Dr. Dilip sir. I would like to thank IMN Nagpur and all the office bearers of IMN Nagpur for giving me an opportunity to speak on osteoarthritis. Being surgeon, my talk will be covering maximum surgeon's perspective of looking at osteoarthritis of the knee. So let me start with osteoarthritis knee. This is the point which I am going to cover: the etiology, pathophysiology, signs, symptoms, investigations needed, medical management, and surgical intervention. So unlike rheumatoid arthritis, primary osteoarthritis is the most common knee osteoarthritis. Secondary to inflammatory to traumatic, post meniscectomy surgery or infective is there, but primary is the most common cause. So to me, primary osteoarthritis, it's not a disease, but rather it's an aging process. The same way, your hair grows gray, it's not an disease, it's an aging process. Similarly, primary osteoarthritis is an aging process and not a disease. This is a normal knee, which consists of 3 bones, femur, tibia, and patella. There are 4 ligaments, 2 cushions called as meniscus, and a smooth covering on each end of the joint called as cartilage, which plays a very important role. So all these 4 ligaments, the meniscus and the cartilage, all plays a very, very important role in normal function, biomechanics, and kinematics of the knee joint. So any structure per se, if ligament is damaged or meniscus is damaged or some traumatic injury to your cartilage will derail the normal function and biomechanics of the knee. So from surgeon's point of view, any full thickness ligament injuries or meniscal injuries need to be treated accordingly and should be taken into consideration to prevent the onset of osteoarthritis early in the age. So these 2 ligaments, MCL and ACL, have major role to play when it comes to replacement, but all the 4 ligaments play synchronously with each other so that the knee bends and in flexion and extension in a proper synchronized manner, and you are able to run with the stability in the knee. So this is how the normal cartilage looks from inside. This is an arthroscopic view of a knee. The one which I am palpating is the meniscus. This is very important structure of the knee joint because they act as a load sharing and load distribution. There are 2 meniscus, medial and lateral, and the covering on each bone, which you look as a pristine clear, is the cartilage. Above is the thigh femur and the lower one is the leg bone, tibia. So any injury to the cushion will have a direct contact of the cartilaginous end of both the bones and will lead to early for degeneration of the cartilage. So this meniscus plays a very important role in delaying the onset of osteoarthritis. And this is how an early or degenerative cartilage will look from inside. As shown in the last video, it was pristine, clear and smooth, and here you see the fibers coming out and the cartilage getting peeled off from the underlying subchondral bone. So this is the form of early osteoarthritis where there is delamination of the cartilage and it looks like that. And these are the pictures of the knee where it's a very severe form of osteoarthritis where the cartilage is totally worn out and whole of the subchondral bone is visible. So this is the advanced form of osteoarthritis which has to be treated surgically only. And if you keep delaying on this advanced osteoarthritis, then you develop the deformity or even bone loss, which you see in the extreme right lower picture where the tibial bone has completely gone down and there is a scalloping. So that's an advanced form of osteoarthritis which leads to bone loss as well. So what are the signs and symptoms of osteoarthritis? Pain predominantly is the one which the patient have. Second, there is difficulty in walking and climbing. Patient always says there is some deformity which is developed gradually in the knee and the knees have become crooked. It's extremely difficult for them to move, as this lady, very slow walking. You can see how the knees have been bowed down. See the difficult time she is taking even to turn around because of the pain and bowing in the knee joint. So this reduces the mobility of the knee joint and waddling gait, and of course they do have some stiffness because of this. One point which I would like to clear here is most of us, including our orthopedic surgeon and physicians, they tell the patients, please carry on with this arthritic knee till the time you are able to walk, and prefer surgery only when it's very difficult for you to walk. I'll take it in the other way. When your clinical picture, your radiological picture and orthopedic or your physician assessment says that you have reached a grade 4 osteoarthritis, irrespective of your age, And if you are walking about say half a kilometer but with pain and deformity, do not wait and delay. Consider knee replacement early if the disease has reached to that stage, instead of telling to our patients carry on with anti-inflammatory drugs and other things and pull on. What happens if you pull on? The mobility of the patient reduces significantly, and if they come when they have almost homebound, by the time they are homebound, the muscles become extremely weak and the osteoporosis sets in. And at that time, if they undergo knee replacement, there is a very delayed recovery. So what I feel, a patient whom it's a complete grade 4 osteoarthritis, he is walking, and we know now the medical management or physical therapy management will not play any role. They should be advised surgery so that you have a good recovery post-op. Investigations in osteoarthritis are very simple. You just need to have a simple routine AP single leg standing X-ray. Most of us, even physicians nowadays, have their X-ray facilities at their hospital. So I'll request them to take a single leg AP standing. Why single leg? Because we always walk on one leg, and when we walk on one leg, the whole body weight comes on that knee. So need to know the condition of the knee when it is bearing the full weight of the body, not in the lying position. Lateral and skyline view are necessary to know the patellofemoral status, and the standing scanogram. What is that? I'll show you in my next slide. So the pictures below show the normal X-rays on one side and the very deformed and bowed knees and completely arthritic knee X-ray on the other side. You can see the difference between the two knees only on the X-ray itself. Now, what is standing scanogram? Let me illustrate to you. So whenever we stand, the weight of our body goes from the spine to the center of the hip, to the center of the knee, to the center of the ankle. So your weight bearing axis goes exactly from the center of your knee when your knees are normal, as shown here by the red line. Again in the other knee, as you see, from the center of hip to the center of knee to the center of ankle. This is the normal alignment of our limb, and that's the weight bearing axis. When you start developing a little amount of osteoarthritis, the weight bearing axis shifts medially, because varus is the most common deformity seen in our population. So the weight bearing starts bypassing the knee, and as you see in the middle X-ray, the weight bearing is going medially on the medial compartment of the knee and not through the center. So this is the early stage of osteoarthritis, or deformed knee, where the weight bearing goes, and it will increase the degeneration further. And in the advanced stage, you see the weight bearing axis completely bypasses the knee joint. So the weight from hip directly goes to the ankle. So that means your joint has considerably got damaged. The knees are bowed, there is deformity, and there going to be a stiffness. And patients walks with a waddling gait. It is as if a stick which you bend, you know that there is a pressure inside and the weight bearing goes from one end to the other end. So this is the advanced form of osteoarthritis where no medical management will work. So this is the classification: acute stage, grade 1, 2, 3, and 4. So grade 1 and 2 very well managed with physical therapy, some lifestyle modifications. Stage 3 and 4 will need some surgical intervention. So what medical management, as rightly told by Dr. Dharmanand, we still don't know what medicines works on primary osteoarthritis, but being a surgeon and a physician and a doctor, if you don't prescribe any medicines to the patient, they feel very bad and awkward. So I term these medications as happy masala to my patients. They take it without any side effects or not much side effects. But the most important thing in medical management of primary osteoarthritis is activity modification. As the arthritis sets in, we advise a patient two major things: not to sit cross-legged and do squatting. The reason behind that is, if you squat and sit cross-legged on the floor and get up from that position, 7 times of your body weight comes to that knee. So the knee which is already diseased, and you give them such a weight, the degeneration will progress very fast and the knee will damage soon. So this activity modification is necessary. Secondly, a weight reduction or weight control is a must. And I'll always advise my patient, irrespective of the osteoarthritis stage, whether it's grade 2, grade 3, or grade 4, keep continuing walking. In fact, if you don't walk and you sit also, the disease is going to progress. But with walking, there are a lot of advantages, like the muscle strength is improved, the bone strength is improved, the stiffness will little bit go down, and you will have a good mobility in your knee or other joints. So walking is an important exercise to all my osteoarthritis patients. Physical therapy, various exercises are there, which is going to be covered by our next speaker. Corrective braces are there, which a lot of advertisement goes in paper, on TV, and other things. Uh, they are useful in stage 1 and stage 2 of osteoarthritis, but this corrective valgus loading or medial offloading braces are really very cumbersome and very difficult to put, because it puts a lot of pressure on your thigh and leg muscles. So personally, I don't advise them, but if some patient comes and says they are using it, if they're comfortable, I say, okay, please go ahead. The second thing, a lot of oils and other things marketed by various film stars and others, that they'll give you 100% relief and all. I think all this, they are playing with the fear of the patient to take them away from the surgery. They do work, but they won't correct the deformity of the knee or the degeneration of the cartilage. I think this specifically works in relieving some stress in the nearby muscles and helping them to get relief of the stiffness to a certain extent, and that gives some mobility to the patient. NSAIDs, as told by Dr. Dharmanand also, they play a very minimum role, so we advise them to take on and off. Nutraceuticals in the form of glucosamine and other things do play some role in early but not definitive role, and there, as I told you, it's just an happy masala to our patients. Vitamin D and calcium definitely to overall well-being of the bone, and viscose supplementation injections, a highly controversial topic, but it works in stage 1 and stage 2 osteoarthritis equally well like the physical therapy. So this is all about the medical management of osteoarthritis. The first and the foremost will be the activity modification and physical therapy. Let's move on to the surgical management of osteoarthritis. It starts from knee preserving surgeries to partial knee replacement, that is robotic assisted, and then to the total knee replacement surgeries. What are all knee preserving surgeries? As I told you, the cushion plays a very important role, and this meniscus, they usually gets damaged in early age, or you may say it's a sports injury. So if that cushion is damaged, we do arthroscopic repair of the meniscus. As you seen in this video, there are small threads which I have tied through an arthroscopic surgery, and you preserve the meniscus because they are load bearing and load sharing, and prevents the prevent or delay the onset of osteoarthritis. And if there is some ligament injury, you need to reconstruct the ligament if patient complains of instability, so that the cartilage doesn't get damaged, because cartilage is one of the notorious structure in the body. A lot of research is still going on how to regenerate the cartilage and delay the onset of osteoarthritis. Some patients do have some problem with the subchondral bone, because the cartilage gets its nourishment from the subchondral bone. It itself doesn't get nourished. So any injury or insult to the subchondral bone differs the cartilage from its nourishment, and the cartilage becomes damaged. As a video shown here, this is a small guy, 20 years age, physiotherapy student suffering from osteochondritis dissecans of the knee. Such a huge defect in the subchondral bone, and the total loss of focal loss of cartilage only in the one aspect of the knee. If you leave it like this, he will soon develop osteoarthritis at the age of 25 and 30, and then that will be a very bad scenario. So in younger patients, I do some cartilage regeneration procedures as well. The picture above shows an autologous chondrocyte implantation, where we take a part of cartilage, send it to the cell culture lab situated in Lonavala. Then they recreate lots and millions of chondrocytes. They send back to us, and then we paste it on the damaged part of the cartilage. Other procedure in the lower pictures is mosaic plasty, where we remove the osteochondral plug from non-weight bearing area of the knee and put it in the weight bearing area of the knee. All these procedures are done in younger age, say less than 40 years of age, provided the knee alignment, the weight bearing axis is neutral from the center of hip to the center of knee to the center of ankle, and patient have only a focal cartilage lesion, the lesion affecting only one part of the knee and not the generalized disease. So this cartilage regeneration procedures has to be considered whenever you have younger patient with focal cartilage defect and to delay the generalized osteoarthritis. Other procedure which patient comes in 40 to 50 of say 55 years of age with medial knee joint pain, that is the time where we should consider this long leg standing scanogram and carefully examine clinically where the joint is, where the pain is coming from, whether it's on the medial joint line, whether it's a patellofemoral pain, whether it's from the lateral compartment. Sometimes it comes from the hip too. So need to check a joint above and a joint below. This is a lady who is in her 50s. She had suffered a ligament injury 2 years back and someone has advised her conservative management. As you see in the MRI image below, there is a PCL ligament avulsion which is 2 years old and it was treated conservatively, because of which she had developed medial compartment osteoarthritis. Again, the long leg standing x-ray showing me that the weight bearing has started bypassing the center of the knee and it reached to the medial compartment. But she is only 50 years of age. So we calculate what's the amount of deformity with a special software called as Bone Ninja software. And we are planning to do high tibial osteotomy where we change the weight bearing axis and give the patient a normal weight bearing axis and a normal knee. So that's the hinge point and that's the angle of deformity which patient have. So she is suffering from 9-degree varus deformity at the knee level. So what we do in such case, we do high tibial osteotomy. We don't touch the knee itself. We go on the tibia and do this surgical procedure where we literally open the medial tibia at the angle what we have done a pre-op calculation of 9 degree. We open the tibia for that much extent, put the bone grafts and fix it with plate and screws so that the axis changes. As you see 3 months after surgery, that's the other knee which is still in varus, but the one which is operated, the weight bearing axis have been changed from medial again to the center of the knee. This is called as offloading surgery so that the damaged part is offloaded and the weight bearing goes in the normal compartment of the knee. This will delay the onset of osteoarthritis and we can give this patient a normal knee for another 10 to 15 years by the time she becomes 65 and she is ready for knee replacement. Sorry, I went back. As you can see in the picture, the operated leg has become straight and the unoperated leg is still crooked. This patient is waiting for next site to get it done soon. This is a young guy who is a 35-year-old, had some ligament injury, underwent that surgery, but due to some reason that didn't work. And see the gait of the patient. You can see the knees are in a varus knee, that is bow knees. Both the sides knees are varus. Sometimes you have a physiological varus in some patients, which is normal. As in this patient, one side it's physiological varus and the other side it's a pathological varus because of the ligament injury which went wrong and he had developed osteoarthritis. As seen in this arthroscopy video, the one side you can see the fibers of the cartilage coming out at the age of 35 years. If you leave these patients like this, they'll come in 2 or 3 years of time at the age of 38 and 39 with a completely damaged knee, and you can't do knee replacement at early age because knee replacement has its life. It can't last for life. So in these younger patients, again, we open the tibia bone, we do corrective osteotomy and fix with plate and screws. And soon after fixing, you can see the weight bearing axis shifts from the damaged part to the healthy part and the knee becomes straight and they have full movements and do all activities which a normal human being can be done. So knee preserving surgeries, if indicated, should be picked up soon and get done so that you can delay total knee replacement surgeries. So very specific indications one should know, and they should have proper radiology, proper angle calculations, and proper counseling of the patient. What is this surgery for and why are we doing it? It gives a very rewarding results if picked up in right indications and delay the knee replacement to a considerable age where we know that patient will need only one knee replacement surgery in a life. Another form of surgery for knee osteoarthritis is partial knee replacement surgery. The prerequisite or the indications for this is a medial grade 4 osteoarthritis of the knee joint. Second, the ligaments should be intact and the other compartment of the joint should be normal. So it's usually done only in one compartment of the knee which is damaged, and rest all of the knee like patellofemoral or lateral compartment is normal. As you see in this patient, only one side of the total medial femoral condyle cartilage as well as tibia is gone, but the other side of the knee is pristine, clear and normal, and even the ligaments are intact. So in such conditions, we offer them half knee replacement surgery. The advantages of doing half knee replacement is that you resurface only the damaged part of the knee and the rest whole normal part of the knee is preserved till the time it becomes damaged. So this is a knee preserving surgery. What does robotics done is, as I mentioned you, that the weight bearing axis goes from the center of hip, knee and ankle. So it calculates your ankle center first, it calculates your hip center, then it tells me the knee range of movements you have. It takes the virtual image of your distal femur on the computer screen. Similarly, it takes the virtual image of your proximal tibia on the film. And then it gives me this picture on my computer screen, which I can plan my component placement in whatever direction I want, which is much precise to the patient. As you see here, the femur is in 45-degree flexion and 0-degree varus. I've changed it to 40 degree, 0 degree, and this is the way the implant will sit on the bone even before I start doing the cutting of the surgeries. Similarly, it tells me that the tibial component will sit in 5 degree of the slope. I need to remove only 3 millimeters of bone. And that's how the component placement will look on my original knee when I'll put it. The most important thing is you need to balance the ligament. As you see in the lower side with the orange color and the black on the femur and tibia, being a varus knee, the medial side becomes contracted and the lateral side becomes open. So you need to balance both the medial and the lateral collateral ligament for normal functioning of the knee. As you see here, the orange line is showing that the medial ligament is too tight. So I do some changes in my planning stage and I got it in the correct position. So pre-op it's a 6-degree varus and post-op I want it 3-degree varus. And it also shows me how the component will move onto each other so as to prevent edge loading and to have a normal knee replacement for 15 to 20 years of life. So this is what I mean to say, and that's how my robotic system works. It's a robotic assisted knee replacement. So this, it allows me to remove the bone which I have planned and it doesn't deviate from the plan. So there is no jigs, no saw, which is used in conventional system. I don't use it anymore. So this pink, blue, green, and white. White is the desired destination where I have to reach. So my robotic arm, after reaching on the white bone, stops automatically and doesn't deviate from the plan. This is what it looks from inside after you have removed that damaged part of the ligament cartilage, and see how minimum the bone is removed and you preserve significant amount of bone for the future. And this is how the artificial implant will look from inside after you precisely place it in the desired direction and desired length and the precision. And this is how it shows me what I have achieved. So what I have planned is 3-degree and I have achieved 3-degree. And that's the whole ligament balance from 0 to 120 degree in the lower graph. So that's how the post-operative X-ray looks after doing half knee replacement. And that's the patient 24 hours after bilateral half knee replacement, walking independently without any support, doing stair climbing because of the precision of robotics and significant ligament balance which I have given with my surgery. And the same patient 8 to 10 days after surgery, walking comfortably at her home with no stress on the knee, no pain, very well balanced, no instability in the knee, no waddling gait or anything. Another patient, day 1 after surgery and third day ready to go home with a smile on her face. So that's the beauty of half knee replacement surgery, which is very bone preserving and it's very precise with the help of robotic system. The last one is the total knee replacement surgery, which has to be considered when the knee is totally fired and there is a severe gross deformity as seen in this patient. It's a 21 and 25 degrees. The weight bearing is completely bypassing the knee joint. In such cases, you can't do any knee preserving or half knee replacement surgery. So in such patients, you need to do total knee replacement surgeries. Total knee replacement surgeries is a boon, and we all are aware that it completely changes the lifestyle of the patient. So it started from conventional knee replacement to computer assisted and now the robotics. It was the success of the conventional knee replacement surgery which has given rise to computer and the robotic assisted surgery to come out with that minute fineness when you need to improve the longevity of that total knee components. So this is how we all plan and assess, as I've already shown this. So this is how the knee looks from inside when you do a total knee replacement surgery and when you remove all the damaged cartilage and the subchondral bone. This is very important because the femur, the thigh bone and the tibia, the component has to be placed precisely in anterior, the distal and the posterior aspect, and also the rotational alignment of the component should be very precise so that you can balance the two ligaments, the MCL and the LCL very well. Because if the ligaments are not balanced well and the component placement is in malposition, then the results of knee replacement will not be good. It's similarly the way the train runs. If the two railway tracks are parallel, it will run smoothly. So if any problem with the two ligaments, the knee will not perform well. This is how your knee component looks from inside after you have done a total knee replacement surgery. It has to be fixed well and the component position should be precise and perfect with individual anatomy. Every one of us have the same knee made up of same bones, but there are certain angles which are variable to each of us. That has to be taken into consideration to have a good total knee replacement surgery. This is balanced and this is how the weight bearing axis completely changed from 25 degree to a complete straight knee. So this is the gentleman who was unable to walk, the same one which I have shown the x-rays. He was unable to walk without walker since last 8 months to 9 months. See the deformity in the leg. It was just mere the fear of the surgery that he was delaying it so much. And this is 10th day after surgery. He is using a stick, walking very confidently. And that's 28th day after surgery. All this because we have balanced the two ligaments very well and placed the components accurately in the position which is accurate for that particular patient. That's a boon, knee replacement surgeries. Is it that patient can't do physiotherapy and very painful knee replacement? With the advent of analgesias, with the advent in the surgical handling of the soft tissues, and with the advent in the component placement for robotics, the patient starts exercise on their own 24 hours to 48 hours after surgery. And this lady, after bilateral knee replacement in single sitting, doing all exercise on her own and even walking without support because of the fineness and precision of knee replacement surgeries. This is the last one. See the pain with the lady is walking. She's with so difficulty she is able to take the steps. See the pain on her face. She's unable to even put a steps of few millimeters away. And that's after bilateral robotic assisted total knee replacement surgery. The whole lifestyle has been changed and the patient is quite comfortable and walking without any pain immediately after surgery. I like to end with this study of ours from our hospital. It's a prospective study of 63 patients who underwent robotic assisted knee replacement surgery. It clearly mentions that it has a very precise and perfect limb alignment and it has reduced the outlier from 3 degree to 1.2 degree in overall limb alignment, and the component placement malposition is less than 1 degree. Thanks a lot for everyone for patient here.
Thanks, Mukesh. That was quite informative. Mukesh, you have got a question from Dr. Nitin Gupta. Should a young patient with post-traumatic arthritis be offered replacement?
It depends on which kind of osteoarthritis it is, whether it's only single compartment, only medial compartment involved, and or lateral compartment. And if the patient is really young, less than 50 years, and I know that's only one compartment is involved, I can give him corrective osteotomy and try to preserve the knee. But that, as I told in my lecture, you need to have all that angle calculations, the scanograms, and then we need to offer. Sometimes if the very bad knee at younger age, you need to replace, but in younger age, we can definitely give a knee preserving or half knee replacement surgeries, partial knee replacement surgeries to the patients.
So I think you would like to say that in a younger patient, you will go for a knee preserving surgery first. Either it can be an high tibial osteotomy, corrective osteotomies, or cartilage replacements or cartilage regeneration procedures. And in a later age, definitely either uni or total knee replacement. That's what you want to convey?
Yes, yes, yes. Okay, because
yes.
Knee replacement is artificial thing which has certain life. So younger the patient, they will use it more and it will fail in 15 years of time. So if you operate any patient, say around 45 years with knee replacement, he'll come back to you around 60 for revision. And believe me, remarriages are painful.
Agree. So thanks, Mukesh.
Thanks, Dr.
Now I would like to have Dr. Sudhir Nath Sukhe. He's a consultant physiotherapist at Karnataka Rheumatology and Immunology and Autoimmune Center. Dr. Sudhir, after completing his Bachelor of Physiotherapy, has done a course in Advanced from American College of Rheumatology. Then he has a PG diploma in manual therapy, and he has completed his postgraduate MPT in orthopedics. Dr. Sudhir's main focus is on musculoskeletal disorders and exercise designing for musculoskeletal disorders and rehabilitating patients with rheumatoid disorders. So I hand it over to Dr. Sudhir now.
Good afternoon, everyone. So I would be talking on few exercise tips for arthritis patients and a very few tips for the doctors too. Are my slides visible?
Yes, we can see that.
Okay. Okay, I would start with principles of exercise. The principles of exercise would depend on, the types of exercise that we are going to teach the patient, depending on their condition and what duration they have to follow the exercises and how frequently they have to do the exercises and what kind of intensity, depending on their condition again. And the volume of exercises is like, it is the sum of intensity, frequency, duration, and longevity of a physical activity program. The phases of arthritis. Designing of exercises always depends on the phase of arthritis. Like the acute phase, we don't do much, as in we just follow the rule of Rice, which is resting the joint at acute stage, giving ice on an acute red.
So the slides are not visible.
You're not, that was what I was asking for. I'll just
slides are not visible. I mean, originally it was visible, then it disappeared.
Okay.
So you can just click on escape button and then again play the slideshow.
Hold on. Screen sharing is paused. Now, sir?
Now it comes. That play in this mode only.
Okay. So I'll start it back with the principles of exercise, types of exercise, depending on the condition and the phases of arthritis, to what duration you need to work out and do exercises, the frequency, how frequently we should be doing the exercise, and the intensity depending on, again, whether it is an acute phase or a chronic phase or a moderate phase. And then the volume of exercise is the sum of intensity, frequency, duration, and longevity of a physical activity program that needs to be done. So when you divide the phases, acute phase, we do not much except following the RICE rule, which is resting, icing, and compressing and elevating the acute affected joint. Like at a chronic or maintenance phase is where you need to work on exercise and protection of joints. Why exercise is vital? That is more important to discuss. Exercise is important to strengthen the muscles around the joints, basically help you maintain bone strength, give you more energy to get through the day, make it easier to get good night's sleep, help you control your weight, enhance your quality of life, and improve your balance. Exercises for arthritis, even before prescribing exercise, or as a patient, if you're starting any form of exercise, you need to first check with your doctor or the physiotherapist, like what kind of exercise and when to exercise, what to do and what not to do before exercise and after exercise, and the types of exercise that you need to do. If you go with the basics of exercise, you have range of motion exercises, strengthening exercises, aerobic exercises, and a few other forms of exercises. Like in the post-acute phase, I mean, once the patient's joint swelling and pain is a little minimized, then you start off with range of motion exercises, which can be a warm-up kind. Like if you see in the picture, you can see a few neck ROM exercises where it is just a flexion, extension, and side rotation of your neck. Coming to your shoulders, your abduction, flexion, extension, internal and external rotation of your shoulder joint is also a RM exercise. Wrist extension, flexion, and radial flexion and ulnar flexion is also an RM exercise for the wrist joint. Coming to the lower limbs, the flexion of hip, extension, abduction, adduction, the foot upward and lower movement, and the rotation is also RM exercise. And coming to strengthening exercise, they help you in build strong muscles and support and protect your joints using any external weight or your own body weight. Like if you see in this third picture, you are using your own lower limb weight to strengthen your quadriceps muscle. The other two pictures show using a dumbbell as well as the newer techniques like TheraBand, wherein you are using an external appliance to strengthen your muscles. The third one is the aerobic form of exercise, which helps in overall fitness and cardiovascular health. It also helps in controlling your weight, improving your stamina and strength. Most of these activities like cycling, regular walks, skipping, and swimming, any water exercises are a good form of aerobic exercise without straining more of your joints. You feel more lighter in water to do exercises, so you can do more repetitions and for much more time compared to doing it outside the water. Other exercise forms, gentle forms of yoga and tai chi, can help you improve balance. They can help you in preventing falls, improve posture, coordination, and also promote relaxation. In both forms, you should be sure to inform your instructor about your painful joints so as to avoid certain positions or movements that can worsen pain. So certain positions of yoga as well as tai chi can be quite painful, like squatting, padmasanas and vajrasanas can be avoided in arthritis patients, which can be quite painful actually. This slide is a little cumbersome, but I'll go through quickly. Tips to protect your joints: start slowly to ease your joints into exercise if you haven't been active for a while at all. So you'll have to start with warm-ups, or maybe a 5 minutes of exercise is more than enough to start off. If you push yourself too hard, you can overwork your muscles and worsen your joint pain. Keep the impact low. Low impact exercises like stationary cycling, exercising in water help keep joint stress low. Apply heat. Heat can relax your joints and muscles and relieve any pain before you start. So even before exercising, maybe use hot packs and then start off with your warm-ups. Move gently. Move your joints gently at first to warm up. Start with ROM exercises always. Go slowly. Exercise with slow and easy movements. Pace up and take breaks. Pace up is to, uh, I mean, pacing your exercise at a gradual intervals is always important, and take micro breaks between maybe every 1 minute of exercise. Take 10 seconds of gap, and then ice afterward. Apply ice to your joints up to 10 minutes as needed after activity. And uh, always end your exercise with a cool down process. A few joint protection tools wherein you can advise and use splints, walking aids, orthotics, and modification of your workstation and home atmosphere. These are few splints wherein used. This is a finger splint, which can, at a moderate stage, can avoid deformities in the PIP joints. This is a wrist supporting or extension splint, which is supporting both, the PIP, MCPs, and the wrist joint also. These are different varieties of walking aids. Like you have a single pod, tripod, and a quadrupod walking sticks, and walker also. Depending on the stages of arthritis and depending on the deformities in the legs, you can advise according to the balance of the patient, and proper advice of how to use on which side, the affected side or the unaffected side, which side to be used has to be mentioned to the patient clearly. These are few orthotics. There's a knee support, as the doctor mentioned. Knee supports may not be advised at the third stage or the fourth stage, maybe in the first and second stage, wherein just to protect your joint from worsening pain, the advice need to be like if the patient is standing for a prolonged amount of time, or when he's walking, or when climbing stairs. I think these kneecaps are advisable, and they are not advisable to be used at a sitting posture at a longer time or sleeping time. Where in the other picture you can see there's a flat foot or a deviation in the ankle angle, where medial wedging can help in keeping the foot at a neutral position. The other home alterations like railings to the walls, where elderly or arthritis people are at home, can help to prevent falls. If you see the first picture, which has a 6-inch to 8-inch toilet seat raiser, which can ease patients to stand or sit easily rather than losing their balance, and to avoid falls also. Railings in washrooms can also help to prevent falls. There ends the tips for the patients. A few fitness tips to the doctors. I think doctors who start their day as early as 8 or 9 a.m. and end as late as 5 to 6 p.m. I think require micro breaks in between their practice. Maybe every 3 to 4 patients, I think they can take a micro break. And there's something called as fitness snacking, wherein rather than working out for 1 or 2 hours in a day, just like snacking in between your meals, I think even exercise or fitness snacking is also good. Maybe a 1 minute or 2 minute break, just walking around to the washroom, or using 2 consultation rooms if feasible, and walking one patient after the other to the next consultation room can give you a small break and a small walk also. And using stairs instead of using elevator, and self stretches like neck stretches, just pushing your head down or to the side, stretching your neck muscles or stretching your shoulders can sometimes help you relief from stiffness after prolonged sitting. And this technique is a good one wherein you can demonstrate few simple exercises to the patient by yourself rather than sending it to your physio. Simple exercises can be demonstrated so that it would be like you are also exercising as well as teaching the patient simple exercises. Using appropriate height of examination couch sometimes helps you avoid back pain, wherein inappropriate size of the couches may require you bending too much or backward bending sometimes if the couch is too high. And using ergonomic chair always helps you keeping away from back pain. This is very important even for the IT crowd or anybody who is using a table and chair, wherein supporting your forearms on the table while writing a prescription or typing a prescription on your systems is equally important. I think I would end there, sir. Thank you so much.
Thank you.
Any questions you can please ask.
There is a question for, yeah, I think there's a question for Dr. Mukesh there. Thank you, Dr. Sudhirnath. That was quite helpful tips for doctors. Hope it helps. Now take over this to the diet. So I'd like to invite Dr. Seema Agrawal, Chief Dietitian and HOD Dietetics Department, Kingsway Hospital, Nagpur. She has done her Masters in Food Science and Nutrition and UGC NET Food and Nutrition. She has been serving as a lecturer and faculty in Masters program, and she has worked at Wockhardt Hospital, Nagpur. So I would like to invite Dr. Seema Agrawal for her talks on the anti-inflammatory diet.
Yeah, first of all, I thank each one of you and IMA Nagpur for giving me this opportunity. So starting with the anti-inflammatory diet. So as we all know, inflammation is the first response of our immune system to heal our body, and the symptoms are redness, warmth, pain, swelling, loss of function. So inflammation is there. Initially, it is a beneficial process when you have an injury, when you have a wound, when you get an infection. But then when it becomes chronic, when the inflammation is not shutting off, then where it brings you to a place where you can land up into some kind of autoimmune diseases, and chronic inflammation becomes the major reason for the underlying major diseases. So the markers are C-reactive protein, homocysteine levels, the CBC and the WBC count. So just coming down straight away to the causes of chronic inflammation. First is the weight, and obviously the excess weight brings in insulin resistance along with it. Then high and prolonged stress, pollutant exposure, lack or too much of exercise, lack of poor quality sleep or sleep deprivation. Then prolonged sitting is also correlated with inflammation. Then nutrient quality or the poor diet, allergies, sensitivities, gut and immune disorders, and dysbiosis, chronic infections, and leaky gut syndrome. So what are the major inflammatory foods? White sugar being the major culprit. We are supposed to cut down on the refined sugars and the simple carbs. Gluten sensitivity, which is now a major concern. Why? Because there is a genetic mutation in the crop itself. So 60% of the population is we have observed that they are not digesting gluten. So that is a pathway to create more of permeability, excess permeability, intestinal permeability. It increases, and that's why leading to leaky gut syndrome. Then refined grains and refined cooking oils, especially trans fats, then grain-fed meats, alcohol, allergies and sensitivities, and ready-made juices. So the anti-inflammatory diet consists of firstly, the low glycemic load food. So basically, we have to control the carbs, and we have to select mostly low glycemic index fruits and other foods which are usually high in fiber, both soluble and insoluble, making it even more better to reduce the inflammation. Then complex carbohydrates are always rich in fibers, antioxidants, mostly the vitamins like vitamin C, vitamin E, tocopherol, and vitamin A. All these vitamins act as a super antioxidants. Omega-3 fatty acids, and we have to use our healthy fats wisely, because there are types of fats, like we've got omega-3 fatty acids, we've got omega-6 fatty acids and trans fats. So basically the culprit here is the trans fats. And also the ratio of omega-6 and omega-3. So what are basically trans fats? Trans fats mostly found in all the processed foods, which is coming directly from the industries, like the chips and the cream biscuits, the hydrogenated fats, the vanaspatis and daldas which they use in the products, and also the samosas and kachoris. Those are deep fried in the oils which are reused by the vendors. So these oils are rich in trans fats, and these trans fats, when they get into our intestine, they increase inflammation. So no refined and processed foods, because usually the fancy items, or the fast food consists of refined foods like maida and all, which is really difficult to eliminate from the body also, which causes a lot of constipation, and also adds up to the weight also. So the weight management is the key. Next thing is intermittent fasting or dry fasting. It can be considered as a very good tool to reduce inflammation. I have used intermittent fasting for patients with arthritis, for SLE, and other autoimmune diseases, and they have noticed that the symptoms have reduced, the pain has reduced. So the intermittent fasting is basically we have to follow a clock in which you can gradually increase the fasting hours, because if you're not habituated of fasting, you should not directly jump to 16:8 ratio, in which 16 hours is the fasting window and 8 hours is the eating window. So in 8 hours we have to set the routine of the eating, the daily routine of the diet, and we have to uh, give them, all rich antioxidant foods and all omega-3 fatty acids and all nuts and seeds and all healthy items to be included in these 8 hours. Then if you have sensitivity to gluten and lactose, you have to check yourself. Like, you can abstain yourself from gluten-rich foods like wheat and dairy products for 2 to 3 weeks, and then you can see yourself whether you are getting benefited out of it. Because there are few people, those can tolerate lactose, those who can tolerate gluten, so there is no need of stopping down gluten and lactose completely from the diet. So why is gluten so much responsible for inflammation? Gluten can be looked on as a biological door to inflammation. It is known to increase an enzyme called zonulin, which controls intestinal permeability and blood-brain barrier permeability. Can then result in cross-reactivity with other food proteins, resulting in multiple food sensitivities. Gliadin has the capacity to activate cytokine production in monocytes and macrophages. Gliadin produces potent induction of pro-inflammatory genes, indicating that gliadin and its active peptides are capable of increasing expression of the repertoire of inflammatory genes. How come the leaky gut syndrome leads to autoimmune diseases? What happens is when because of the leaky gut syndrome, when the absorption of the nutrients from the villi goes to the blood, but then when there are breaks in the gut lining, and when they directly go undigested or toxic ingredients, when they directly enter to the bloodstream without proper absorption and all, so and this permeability, this keeps increasing, the holes become bigger and bigger. So this repeated insult and injury to the gut lining, that increases the pathway to the autoimmune diseases, because the immune system cannot handle so much of toxins. So the reasons could be chronic antibiotics or anti-inflammatory drugs, mercury dental fillings or heavy metal exposure, traumatic brain injury, chemo or radiation treatments, cesarean births and limited breastfeeding, gut dysbiosis or bacterial imbalances. This is very important, because of which in the anti-inflammatory diet, we stress a lot upon prebiotics and probiotics and also symbiotics. So these prebiotics, they help us, for the healthy flora or the healthy bacteria in the intestine, which helps to reduce the inflammation. Hormonal imbalance, chronic inflammation, vitamin and nutrient deficiencies, mostly the vitamins, which we have found responsible. Then coming down to fats, as you can see, the omega-3 and omega-6 ratio is supposed to be 1:2. But then what actually we are eating is this is the reality. So actually we have to focus on the good fats, which are the unsaturated fats, and they are coming from the nuts like almonds, walnuts, olive oil, oatmeal, avocado, sesame oil, that is the till oil, and soya beans. So saturated fats like butter, creams, high fat cheese, palm oil, kernel oil, they're all bad, and trans fats especially are very, very bad for the inflammation. Omega-3 anti-inflammatory effects. You can include fishes like salmon, sardines, black cod, and nuts like walnuts, seeds like flax seeds, hemp seeds, and even the Brazil nuts, which are also rich in selenium, kelp and fish oil supplements. Omega-6, like oil-rich seeds, oil extracted from seeds used in snacks and fast foods. So they are pro-inflammatory, basically. Proteins, eat more vegetable protein like soy food, beans, lentils, and other legumes. Whole grains, seeds, nuts, and oily fishes. Soy food contains isoflavones, which have antioxidant activity and have been suggested to lower CRP and inflammation levels. Eat less meat and poultry, which contains pro-inflammatory fats. Then coming down to carbs, we have to, go for complex carbs and avoid simple carbs, especially the high fructose corn syrup, which is responsible for increasing inflammation immediately. Then white breads, white potatoes, chips, pastries, all these things. And beneficial phytochemicals and antioxidants digest slowly, reduces blood sugar spikes, which promotes inflammation. So whole grain, which is brown rice, bulgur wheat, or you can take a khapli wheat. A khapli wheat is a gluten-free wheat. Beans, sweet potatoes, winter squashes, berries, cherries, apples, and pears. These are good forms of carbohydrate which you can include in the diet. So the top anti-inflammatory foods are turmeric, cinnamon, ginger, rosemary, clove, pepper, cumin, and more spices, organic blueberries, cherries, raspberries, acai berry, coconut oil, and green tea. Vitamin D plays a very important role. I will see forward why it is important. Enzymes and probiotics, which are found in fermented foods, raw fruits, and vegetables. Omega-3 fatty acids, chia seeds, flax seeds, and oily fish, and also cruciferous vegetables, which is the cruciferous families like cabbage, cauliflower. All these vegetables plays a very important role. In the turmeric, curcumin is the potential bioactive compound. It is anti-inflammatory, neuroprotective, liver supportive, and antioxidant. So I've brought this slide which shows how curcumin blocks uh, inflammation and how it activates apoptosis and DNA repair and cell cycle arrest. But there is one thing I have to add for curcumin. Curcumin is not bioavailable to us just when we take curcumin. It has to be clubbed with black pepper. Then the bioavailability increases. Then it is actually absorbed and it will actually work in the body. Ginger, the active compound is gingerol. So we all know it is anti-inflammatory. So there are a lot of herbs and spices. There are scientific proofs and evidences which has proved that they are potential anti-inflammatory substances. Vitamin D deficiency can have a profound effect on immunity, inflammation, and muscle function. Adequate vitamin D status may reduce fractures, stress fractures, total body inflammation, common infectious illnesses, and recovery from injury. So who needs more and why? Older people, particularly those who are housebound with limited exposure to sunlight, those with darker skin color, those living in further away from the equator during the winter, those working indoors. Coming to probiotics, especially the lactobacillus species, play a significant role in anti-inflammatory, antiviral, and antimicrobial activity of a host's immune system. Could give a whole presentation on probiotics and inflammation alone due to the host gut and immune system. So enzymes like papain, which is found in papaya, bromelain, which is found in pineapple, these are proteolytic enzymes with anti-inflammatory function. They are found in fresh, raw fruits and vegetables, and very high in fermented foods. Then coconut oil, especially the raw, cold-pressed coconut oil, is very, very good for anti-inflammation. So usually we suggest in the morning we suggest 1 teaspoon of extra virgin coconut oil to be taken as a supplement. Then catechins, they bind the free radicals. So the catechins, the free radicals damages and increases inflammation. So green tea, black tea, the cocoa, garlic, red pepper, red grape skin, blackberries, raspberries, and cherries. They're all rich in catechins. Polyphenols, they're all found in the spices and the fruits and vegetables, roots, all anti-inflammatory, rich in with rich anti-inflammatory properties. Berries, as I've told you. Ghee, which is a great source of butyric acid, fuel for colonocytes. Why? Because we suggest 10 grams of ghee every day, which is like 2 teaspoons, which will help in increasing the intestinal integrity of the intestinal mucosa, and been shown to exert potent anti-inflammatory effects both in vitro and in vivo. Also, this cocoa is also rich in antioxidants. Um, we have also found that sleep deprivation is linked with increased cortisol productions. So cortisol also is responsible, increased cortisol in production is also linked with inflammation. So sleep plays a very, very important role. So basically, trying to sum it up, antioxidant rich foods, herbs and spices, especially cinnamon, which is dalchini, turmeric, ginger, and berries like blueberries, cherries, and raspberries. Extra virgin coconut oil, ghee, chia seeds, fish, flax seeds, fermented foods, probiotic, which will increase our gut flora, the vitamins, which is the antioxidants, green tea and polyphenols, which will include the catechins. So basically, we have to improve insulin sensitivity. So we have to keep weight in management. Like we have to lose weight if your BMI is above 24 kg per meter square. Then sit less, play, move more, address the organ function, breathe deeply, yoga, stretching, meditate, emotional detoxification, and sleep. So that's all from my side. Thank you so much.
Thank you, ma'am. That was quite informative. Any questions for Dr. Seema? Yes. Dr. Dharmanand want to ask role of meditation diet.
Mediterranean diet.
Mediterranean diet.
Sorry.
Mediterranean
Yeah,
diet.
Mediterranean diet is rich in omega-3 fatty acids because mostly it contains seafoods. So basically, it will help you to reduce the inflammation because they are rich in omega-3 fatty acids. Mediterranean diet.
Ma'am, your take on keto diet?
I don't favor keto diet basically. Why? Because it is a fat-based diet. The major ingredient in the keto diet is fats. Rather than keto diet, I would suggest patients to go for intermittent fasting.
Okay.
Because keto diet is like time and again we've come across patients who've told us that they have undergone a lot of vitamin deficiencies because being on keto diet for a prolonged time. So pre-keto diet is basically not practical and not a healthy idea to follow.
Okay. Ma'am, Dr. Suman Rao wants to ask you, peanut is good or bad during starvation windows? What is permitted?
What is good or bad?
Peanut is good or bad?
Peanuts. There are two sides of peanuts. Peanuts are also rich in goitrogens, which are the anti-nutritional factors. So in anti-inflammatory diet, a little bit here and there, like once in a while, or maybe like 2 times in a week is advisable. But then the anti-inflammatory diet will not be rich in peanuts, and especially in the fasting window, we cannot consider peanuts because they are rich in fats and calories.
Okay. And she wants to ask again, during starvation window, what is permitted? I think that's for the
During
intermittent fasting. Intermittent
yes,
fasting.
correct. In the starvation window, the you can go in for black teas, you can go in for green teas. This is the time where you can include lot of antioxidants coming from things like green teas and black teas, and you can at the most go for all such foods which doesn't trigger insulin production. The moment
And what?
the food which do not trigger insulin production.
Okay. And
So
what
like,
about caffeine? Caffeine, ma'am? Caffeine?
some people suggest black coffee, which is advisable during the fasting window because it increases the BMR, the basal
Yes.
metabolic rate of the body. So whenever the body is in the high BMR state, the body is in the anti-inflammatory mode. Whether it is, the BMR, when the BMR increases, the body tends to lose extra fat, the excess adipose tissues. It helps in weight loss. So the body is in a healthy mode basically. So, but too much of caffeine will make you sleep deprived. So the caffeine has to be in moderation.
Thank you, ma'am. Thank you so much. So I'd like to thank all our speakers for this wonderful talk. And now I'll hand over it to Dr. Sachin Ghate, Treasurer IMA, to propose his vote of thanks.
Hello everyone, very nice session. I thanks all the speakers, Dr. Dharmanand, Dr. Sudhir, Dr. Mukesh Ladda, dietitian Seema Agrawal, and moderator Dr. Gilli Prati sir, and our chairperson Dr. Kimmatkar and Dr. Chaube sir on behalf of IMA, and not the least, the last Dr. Shaili Chandak, who has taken all the efforts to organize this webinar. Thank you also the DigiShield person, Mr. Deepen and Mr. Chira. I thank you all of you and have a nice day.